Yeah. Welcome to my channel. Adeshola Onide is my name. In this channel, what I do is to give you learning tips. And sometimes I pick topics in biology and medicine and discuss them in a very simplified manner to aid your study. Always ensure you visit this site regularly. Thank you. Hey guys, if you are new in my channel, please kindly click on the subscribe button to encourage me. Thank you. Part 1 of the video on primary function of GIT, secondary function of GIT, cells of the GIT, then talk about GIT hormone. Then we start conversation on GI disorders. And in this edition, we pick 3: Zuniga Allison syndrome, VPOMAS, then carcinoid disease. All right, what's the primary function of GIT? The primary function of GIT is actually to move nutrients from external environment into the body. Which nutrient are we talking about? We're talking about the nutrient from the food that we consume. When we consume food, the food is digested, then absorbed. The absorbed food into the blood will be carried by the blood to various parts of the body where it will be used. That's actually the primary function of GIT. Although the GIT has a secondary function. Then what are the secondary function of GIT? We have what is called the mass balance. What do you mean by mass balance? We are saying gastrointestinal system contributes to daily maintenance of fluid input and output. That's one secondary function. Another secondary function is protection. We consume most food that we actually consume, they are not as hygienic as we think. The reason why we are not getting sick is because the acid and some other enzymes are also involved in the defense of the body. That is why we are actually not getting sick. Now note, for the maintenance of fluid balance, there's something you must understand, that the input of fluid into the digestive system is actually about 9 liters every day, and the output is also about 9 liters every day. So what contributes to the input? The water the water and the food consumed will account for about 2 liters. Then the secretions will account for about the remaining 7 liters. Secretions, by secretion, we're talking about the salivary gland, the pancreatic secretions, the intestinal juice. These three, 1.5 each, that will form 4.5. Then we have the gastric juice, which is having the maximum volume. Then we have the liver. So all this will form the input 9 liters. Then the output 7.5 will be absorbed by this small intestine into the blood. Then we have another 1.4 that will be absorbed by the large intestine in the blood. Then the remaining 0.1 will be lost in feces. Note that when the amount to be lost in feces is more than 0.1, it will result in diarrhea. Diarrhea is increase in frequency and fluidity of stool. Diarrhea is increased fluidity and frequency of stool, and this will be due to either less absorption or more secretion. Either of these will actually result in diarrhea, and diarrhea is one of the commonest symptoms of a gastrointestinal disorder. Commonest symptoms, commonest sign of gastrointestinal disorder. 3 important things that you should also take note is what is called dysphagia. What is dysphagia? Dysphagia simply means difficulty in swallowing. It is different from ordinophagia. Ordinophagia simply means pain while swallowing. Ordinophagia, pain while swallowing. Now, there's a condition that is very common that you should also know. Not very common though. That is known as achalasia. In this condition, the ring that form the lower esophageal finger usually find it difficult to relax completely, thereby making food to accumulate. Then note that you can classify causes of diarrhea. This increased fluidity and frequency. You can classify the cause of diarrhea actually into 3 important parts, into 4 important causes rather: the infection, drugs, and allergy. Now, when we say the digestive system, what is actually the limit? Digestive system actually start from the mouth and end in the anus. However, there are key organs of digestion, 3 of them: the stomach, the small and the large intestines, which we call together as intestine, and the pancreas. Now, what is the stomach? Stomach is like the store for the food that is coming from the mouth that pass through the esophagus. Stomach is just like a sack that initially store food for a period of time. Then food in the stomach move into the intestine, then from the intestine to the pancreas. Now, if you won't remember anything about the stomach, note that the stomach is having three main parts. We have the cardiac zone, we have the body, then we have the cardiac zone, we have the body, then we have the pyloric zone. So if you are not going to remember anything, you must remember that. Then if you are not going to remember anything about pancreas, know that pancreas is just like a bag of enzymes. A lot of enzymes that are involved in digestion are produced by the pancreas. And intestine is the site for the digestion and the absorption of the food. Just like the same we have talked about the key structure, we should also talk about the key cells of the gastrointestinal system. What are those key cells? The number one, two of them actually, the endocrine cells that produce the hormones, which we call the GIT hormones. There are more than 200 GIT hormones actually. Then we have the one that is called the neuroendocrine cells. Neuroendocrine cells, they produce hormone also, but these hormones sometimes act as neurotransmitters. That's why we call them neuroendocrine structure, or neuroendocrine rather. I mean neuroendocrine substance. They are hormones, but they can act as neurotransmitters sometimes. Now, these neuroendocrine cells are also called the APOD cells. APOD for amine, precursor, uptake, and decarboxylase cells. APOD, amine, precursor, uptake, and decarboxylase cells. Now, these cells, if they become problematic, maybe they get some yawa, this will result in what we call a carcinoid tumor. Now, all right, so with this foundation, we can now quickly go into the cells of the stomach. Now, the cells of the stomach, there are four of them. We have the epithelial cell, which produce mucus, or the mucus secreting cell. We have the parietal cells, which are also called the oxyntic cells. We have the chief cells, which are also called the zymogen cells of the peptic cells. Then we have the enterochromaffin cells. Note that all these three parts of the body produce the mucus. So the mucus producing cells are present in the cardiac of the stomach. They are present in the body of the stomach. They are also present in the pyloric region of the stomach. The parietal cells are the ones that produce hydrochloric acid. Parietal cells secrete hydrochloric acid. They also produce intrinsic factor. What is the function of intrinsic factor? Intrinsic factor is the one response is very important in absorption of vitamin B12. So now, if intrinsic factor is not produced, the implication will be that vitamin B12 will not be absorbed. If vitamin B12 is not absorbed, then the vitamin B12 will not be available for production or the process that is known as erythropoiesis, which is the production of red blood cells, and that may result in a type of anemia in which the blood cells will be bigger. The red blood cells will be bigger than what is supposed to be, what we call megaloblastic anemia. Then the specific type of anemia due to this intrinsic factor deficiency is what we call pernicious anemia. All right, chief cells or zymogen cells, they are the ones that produce pepsinogen. What's the difference between pepsinogen and pepsin? Pepsinogen is the inactive form of the enzyme pepsin. Pepsinogen is the inactive form of the enzyme pepsin. Now, it is hydrochloric acid that is produced by the parietal cells that will activate this pepsinogen and make it active. Now, the next one we should talk about is the enterochromaffin cells. These enterochromaffin cells, they are also very important because they secrete serotonin. They also secrete histamine. This histamine is very important in manufacturing or in the production of hydrochloric acid. All right. So now, the next thing we should talk about are the GIT hormones. GIT hormones can be classified into three groups. GIT hormones can be classified into three groups, just like I stated earlier. We have the gastrin family, the secretin family, and the others. The gastrin family, GC, General Coordinator. This is where we have gastrin and CCK, cholecystokinin. The two of them, they are produced by the G cells. The G cells produces the two of them. Then we have the secretin family. The secretin family secretes Secretary General, SG raised to power 4, secretin, glucagon, glycine, GIP, which is gastric inhibitory peptide, then VIP, vasoactive intestinal peptide, then others, PNBGSM. Please take note of GSM. PNBGSM, peptide YY, N, neurotensin, B, bombesin, GSM, guanylin and ghrelin, S, somatostatin and substance P, then M, motilin. Now, hormones of the GIT, GC, gastrin and cholecystokinin, S, secretin, glucagon, glycine, GIP, VIP, P, peptide YY, ghrelin, motilin, somatostatin, neurotensin, bombesin, substancin, and guanylin. Now, note that the gastrin is the first one we talk about because it's the one that will commence the action that will result in digestion of food after arrival of the food in the stomach. Notice that the stimulus or stimuli for gastrin production, they are actually numerous. They might be due to the thought of food or the presence of food. Now, presence of food substance in the stomach is the main one. Now, especially food substance that contain calcium and protein. So now we can say the source of or the stimulus for the gastrin is actually calcium, epinephrine, peptide, amino acid, then distension as a result of food that is present in the stomach. Note that the aim or the main function of gastrin is actually to ensure that the food that gets to the stomach gets digested without going back to the mouth. Do you understand? And protein is the main product that is digested in the stomach. So meaning, what will you expect gastrin to do? To ensure that pepsin is released for the digestion. However, pepsin is produced in the form of pepsinogen by the parietal cells that we have talked about initially. So, you can imagine what will be the function of gastrin. Arrival of the food in the stomach should be followed by preventing the food from returning into the esophagus. Do you understand? So that means gastrin will, part of the number one function of gastrin is gastrin will cause contraction of the muscle of the gastroesophageal junction. That's one. It will cause the contraction so that the food will not return and cause reflux esophagitis. That's number one. Number two, it will cause growth of the gastric mucosa and intestinal mucosa. Why the growth? So that when acid and pepsin are being released, they will not destroy those structures. That's number two. Number three, it will also stimulate gastric motility so that the mixing with the enzymes will be more effective and the food will be able to move into the small intestine immediately after digestion. So it also stimulates gastric acid production. Gastrin acts on the parietal cells to produce gastric acid. Now, because histamine is needed for gastric acid production, gastrin will also act on the enterochromaffin cells to cause them to produce serotonin and histamine. Histamine is importantly needed for the production of the hydrochloric acid. At the same time, this gastrin also causes development of the parietal cells so that they can produce enough hydrochloric acid. The hydrochloric acid in turn acts on pepsinogen and convert it to pepsin. Apart from that, it also stimulates the pancreas to produce enzymes. Why? So that after digestion has taken place in the stomach and the food has been moved into the small intestine, pancreas can release its own enzyme and the digestion can continue. So now, what is the next hormone we should talk about is CCK. CCK will take the action immediately after gastrin. What is the function of CCK? Actually, to inhibit gastrin. Why? Because acidic medium is required for digestion of enzymes of the stomach, but alkaline medium is required for the small intestine. So that means body cannot continue to produce hydrochloric acid. So CCK inhibits hydrochloric acid production. Instead of producing hydrochloric acid, then CCK will also act on the gallbladder to release bile, which is very important in emulsification of fat. What is emulsification? The process that makes the fat soluble so that the enzyme will be able to act on them. Then apart from that, it will also augment the action of secretin, thereby aiding digestion. Note that CCK will inhibit gastric motility. I've explained that. So that too much acid will now enter the small intestine and cause change in pH. It will inhibit acid secretion. I explained that. It will also delay gastric emptying. The next one I want to talk about is secretin. Secretins are produced in the small intestine generally. Secretin, it is easy for you to remember. Don't forget, I've told you that it is G cells that produce both the gastrin and CCK. So you must have that at the back of your mind. Now, what is the function of the secretin? What is their function? The function of secretin is actually to stimulate the pancreas to release enzymes. Secretin stimulates pancreas to release enzymes. So another thing, the stimulus for secretin production is arrival of acid. Don't forget, the content that is coming from the stomach is actually acidic in nature. So its arrival at the small intestine is what is going to cause release of secretin. You can see that they actually act in a stepwise manner, starting with gastrin. Gastrin will ensure that the food do not return to the esophagus. Instead, they get digested, then we push them into the small intestine. CCK will continue from there, start inhibiting the gastrin, then helping secretin to function. Then secretin will act on the pancreas to ensure that enzymes are released so that this enzyme can continue the digestion. Then the next one we want to talk about is the GIP. You remember the full meaning? All right. So the GIP, which are produced by K cells, and these K cells, they are present in the jejunum, duodenum, or just remember that they are also present. They are present in the small intestine. Then what is the main function of the GIP? Just from their name, gastric inhibitory peptide. Their main function is actually to inhibit the stomach. Don't forget, immediately the food substance has been passed into the small intestine. We want to inhibit the action of the stomach. Why? So the acid will not continue to enter the small intestine and inactivate the enzymes that are supposed to act in alkaline region. You understand? So the main function is actually to inhibit gastric motility and also to inhibit gastric acid production. Then what about VIP? Vasoactive intestinal peptide. They are also produced from the small intestine. Now, note that most of the secretin family are actually produced from the small intestine, so don't be confused. What is the main function? To stimulate intestinal secretion. Why? Why do they stimulate intestinal secretion? So that digestion can occur, and after digestion, we have absorption. We call them vasoactive intestinal peptide. Because of that, vasoactive intestinal peptide, because they are produced in the intestine and they are useful in the intestine. They are vasoactive because they cause vasodilation. Vasoactive intestinal peptide. Now, the implication of this is excess production of this VIP will cause excess vasodilation, and that will result in significant decrease in blood pressure. When we talk about VIPomas, then we expatiate on this. Then glucagon. What is the function of glucagon? Glucagon are produced by the L cells, and their main function is also to inhibit gastric emptying. You can see that most of the secretin family, what they do is to inhibit gastric emptying, inhibit gastric emptying, inhibit gastric acid production. Although this glucagon also inhibits pancreatic secretion, unlike secretin that will stimulate it.
but instead it stimulates proliferation of intestinal epithelial cells. Why? To prevent them from damage. Then the next one we should talk about is somatostatin, produced by S cells or delta cells of the GI mucosa. Note, their stimulus is still acid. Why? What is their function? What's their function? Secretion of gastrin. Their function is actually to inhibit secretion of gastrin. You understand? Why? So that we are still trying to protect the small intestine. Motilin, the function, just like the way it sounds, motilin, the main produced by M cells, the main function is actually to regulate GI motility, contraction of the gastrointestinal tract. Ghrelin, the main function of ghrelin is actually, note that the main function of ghrelin is actually to stimulate feeding. Opposite of ghrelin is leptin, which is another hormone we sometimes consider as GIT hormone. Ghrelin stimulates feeding, while leptin actually inhibits. Okay, now, the next thing we should talk about is the Zuniga Allison syndrome. Now, when you hear the word Zuniga Allison syndrome, the first thing that should come to your mind when you hear the word Zuniga Allison syndrome is gastrinomas. Primary problem is we have tumors, and these tumors that we're talking about, they are coming usually from the pancreas, non-B cell pancreas islets. They are producing excess gastrin, which is the primary problem. We have gastrinomas that produce excess gastrin. This excess gastrin causes increased hydrochloric acid production. Now, increased hydrochloric acid production leads to ulcer. So if you will not remember anything about Zuniga Allison syndrome, remember that there are some tumors that are commonly found in the pancreas called gastrinomas. They are gastrinomas because they are gastrin producing in nature. And you remember the function of gastrin, always regulating hydrochloric acid production. Gastrin primarily act on the parietal cells to ensure they produce hydrochloric acid. Now, because these gastrinomas are producing excess amount of gastrin, then there will also be excess hydrochloric acid production, and this will lead to ulcer. Ulcer in the stomach, ulcer in the intestine, especially. Look at where we can have the ulcer. We can have the ulcer in the esophagus. We can have the same ulcer in the stomach. We can have the ulcer in the duodenum. Then we can have the ulcer in the jejunum. If you understand this, then it will be easy for you to get what will be the clinical features and the laboratory investigation that should be done for a patient with Zuniga Allison syndrome. Primary problem, gastrinoma. Gastrinoma producing gastrin. Gastrin increasing hydrochloric acid production. Increased hydrochloric acid production is increased hydrochloric acid production is resulting in ulceration in the esophagus, in the stomach, in the duodenum, in the jejunum. All right, that's the primary thing. Another thing you should always remember is that this Zuniga Allison syndrome is actually sporadic in nature. The tumors, we just realized this non-beta cells islet tumor that we said is produced from the pancreas, they are sporadic in nature. However, there's about 20 to 25% that is familiar, which is associated with what is called MEN1. MEN simply means multiple endocrine neoplasia, meaning we have many endocrine cancer that are involved. So now we are saying that in men type 1, gastrin can be one of the hormones. Don't forget multiple endocrine. We are saying many hormones are produced, and men type 1 has been associated with gastrin production. Now, just the same thing, the gastrin that is produced acts on the parietal cells. Parietal cells produce hydrochloric acid. Hydrochloric acid will result in ulceration, esophagus, stomach, and small intestine. On that ground, what will be the clinical features? Because of the ulcer in the stomach, what will happen? The person will have abdominal pain. Because of the ulcer in the esophagus, the person will have chest pain. Do you understand? The person will have odynophagia, pain while swallowing. The person will have dysphagia, difficulty in swallowing. Because of the ulcer in the small and large intestine, the person will not really absorb a lot of food like that. The person may have what is called malabsorption syndrome. Then the person will have weight loss. Why? Because the person is not really absorbing a lot of food. Then the person will bleed because of the ulcer. Now, there's the general name for general feeling of unwellness that has to do with GIT is what we call dyspepsia. So those are the symptoms of the Zuniga Allison syndrome. So the triad is this. We have pancreatic tumor, excess gastric acid production, then peptic ulcer. The triad of Zuniga Allison syndrome: pancreatic tumor, which is gastrinomas, then we have gastric juice, gastric hypersecretion, gastric acid hypersecretion, then we have the peptic ulcer. Now, always remember that this ulcer can be seen along the entire GIT, although it is common, it is found more frequently in the stomach and the small intestine. And the treatment is usually either medical or surgical. The medical is by giving drug, the proton pump inhibitors, the omeprazoles, the prazoles and the prazoles. Then the surgery is by surgical resection. They just resect now. But we focus more on the laboratory investigation. All right. Now, what are the laboratory investigations? You can reason it out actually. Now, we have said gastrines. So what do you expect? You can check the pH and there'll be what? Increased acidity. It's that simple. When you measure the fasting gastrine, what will happen? The level will be elevated. Elevated gastrine level. You understand? The next thing, what do you measure? Calcium. Calcium level will be elevated. Why? Because we have told you that is associated, men type 1 is associated with other hormones, and one of them is hyperparathyroidism. And you remember, parathyroid hormone always increase serum calcium. So you can have in men type 1, the one that is associated with men type 1 will be associated with increased parathyroid hormone production. At the same time, it will also be associated with increased calcium production. Why? Because parathyroid hormone can increase calcium level. Then we have said, when they look at, then when they carry out gastric acid secretion test, what are we going to find out? We realize that the basal acid output is elevated. Why? Because gastrin is elevated. If gastrin is elevated, fasting serum gastrin is elevated, then you expect the basal acid output to also be elevated. Then they can do what we call secretin stimulation test. When secretin is administered, what do we expect? We expect that at least it should act against the gastrin. They can do bombesin stimulation test. Then when they do imaging, they will see the sign. They will see the sign of ulceration. When they do protein meal test, also a radiologic investigation that will help us to see all those sites of ulceration. So those are the most important things you need to know. We have said medical treatment is by giving proton pump inhibitors, and we can do surgical resection. Then the next thing we want to talk about is what we call Werner-Morrison syndrome. When you hear Werner-Morrison syndrome, just think of VIPomas. When you hear Zuniga Allison syndrome, what do you think about? When you hear Zuniga Allison syndrome, what do you think about? You think about gastrinoma. When you hear Werner-Morrison syndrome, what should you think about? You think about VIPomas. What do you mean VIPomas? We are saying there are tumors that are also producing excess of VIP. And the problem with now we are discussing VIPoma or Werner-Morrison syndrome. We also call it WIDA. WIDA syndrome. WDHA. The WIDA stands for the common presentation. W, watery diarrhea. WIDA, watery diarrhea that will result in dehydration. That's WD, watery diarrhea and dehydration, resulting in dehydration. H, hypokalemia and hypotension. A, achlorhydria and acidosis. Also, of course, the H can even be H raised to power 4. Hypotension, hypokalemia. Then we have two hypercalcemia and hyperglycemia. All right. You will soon realize how we get all those. All right. Now, note something about VIPoma or Werner, V-E-R-N-E-R, Werner-Morrison syndrome. The problem is we have VIP producing tumor, which are commonly present in the pancreas. Note that this vipoma is the third most common neuroendocrine tumor of the pancreas. Third most common neuroendocrine tumor of the pancreas. It is usually solitary in the body or tail. It's not like it's everywhere. It's usually solitary, found in the body or tail of the pancreas. 2/3 of it is malignant. So majority of it is malignant. It's not a benign tumor. Male to female ratio in children is 1:1, but male to female ratio in adults is 1:3. So meaning in adults it is commoner in females than in males. All right. Another thing that you should know about this vipoma is the fact that the presentation is actually as a result of VIP that is produced in excess. Now, when you have this at the back of your mind, then it will be easy for you to understand what vipoma is. We have said that majority of the vipoma arise within the pancreas. Majority arise within the pancreas. We can have some also coming from the lungs, one, from the colorectal cancer, and they can also be a few chromocytoma of the adrenal. Now, the common age is between 30 and 50 years. That's the common age at which people develop it. Of course, we also have it in children 2 to 4. Remember, I've told you that those that are in children, male-female ratio is 1:1, but in adults, male-female ratio is actually 1:3. Another thing you should note is the fact that it is 60% of it that is solitary, and it is found in the tail of the pancreas. 60 to 80% of it found in the tail of the pancreas. Vipomas have tendency of metastasis. They can move to different parts of the body. Then usually they can also be they are sporadic, and they can be isolated tumor, but they can be part of men type 1, just like gastrinoma. You can see that this men type 1 is very notorious. Gastrinoma is also part of the men type 1. Now, I've told you that the symptoms or the problem is actually due to excessive, unregulated secretion of VIP tumor. This tumor produces a lot of VIPs, and we have receptors of VIPs everywhere in the body. Now, the effects will be that this VIP will bind adenylate cyclase. Adenylate cyclase will activate cyclic AMP production, and this will result in accumulation of fluid and electrolyte within the lumen, so resulting in secretion. Don't forget, I've told you the basis of diarrhea is actually if there is imbalance between secretion and absorption. So meaning either there's a reduction in absorption or there's excess secretion. So the problem here is actually excess secretion. Don't forget there can be diarrhea in Zuniga Allison syndrome too. But in that case, the problem will be absorption because of the ulcer. Can you get it? So know the link. In fact, it might not be a bad idea if one do comparison between the Zuniga Allison syndrome and vipomas. Now, let's look at the clinical features. Onset is insidious. I've told you it's only less than 10%, actually about 5%, that is associated with men type 1. The stool is colorless and odorless. Why? Because there's no infection. It's just that there's excess secretion. It is excess secretion that is resulting in diarrhea. Now, because of excess secretion, what will be the effect? Then that means we are losing water. Because water that should be absorbed, they are now what is being lost in diarrhea. So we are losing water, we are losing sodium, we are using, anytime you are losing sodium, the implication is that you will be using chloride too. Sodium and chloride, they always move together. So body is losing water, body is losing sodium, body is losing chloride. And this is what is going to result in volume depletion. Volume depletion is the cause of dehydration. Dehydration, volume depletion, they are the cause of weight loss. Note, anytime there's hypotension, an individual is also at risk of acute tubular necrosis that can result in renal failure. So you are seeing how we are going to investigate The problem now is excess secretion, excess loss of water in stool. Because of excess secretion and excess loss of water in stool, there'll be excess sodium. Water is always lost. Sodium always accompany water reabsorption. Excess loss of water, excess loss of sodium, excess loss of chloride. All these result in volume depletion and dehydration. This can result in acute tubular necrosis, renal failure, then weight loss. Also, there's excretion of large amount of potassium and bicarbonate, and all this will cause hypokalemia and metabolic acidosis. Now, common thing that is seen is because of all this, we might have abdominal discomfort and bloating. So what are the laboratory investigation? Of course, you can know what the laboratory investigation will be. Serum potassium, what do you expect to say? Hypokalemia. Serum chlorine, what do you expect to do? Hypo. pH level, what do you expect to see? Metabolic acidosis. Calcium, what do you expect to see? Hypercalcemia, hyperglycemia. What about sodium? Hyponatremia. If we do electrolyte urea and creatinine, it will be elevated. Electrolyte urea will be elevated, creatinine will be elevated. You know the reason? Because of the liver involvement. Because of the acute tubular necrosis that can occur, that can result in renal failure. Then there will be abnormal liver function. If we should try and check the plasma VIP assay, it will also increase. If we do imaging, we will actually find a VIP secreting pancreatic polypeptide tumor. A vipoma that is secreting VIP can be seen if we should do imaging. But note that these vipomas can also secrete other hormones like pancreatic polypeptide, calcitonin, and neurotensin. Now, this calcitonin also account for the reason why there is hypocalcemia. Where there is this calcitonin will also account for why there is hypercalcemia. All right. Now, how do we manage them? You correct electrolyte imbalance. Then the medication that can be given is octreotide acetate. Why octreotide acetate? Because we have realized that can actually regulate diarrhea. It's a somatostatin analog. So what it's going to do is going to act against, is going to analog that helps to decrease release of GIT hormones generally. Remember, when we talk about somatostatin, we said they reduce somatostatin generally reduce GIT action of GIT hormone generally. They act on gastrin, they work against gastrin, they reduce pancreatic secretion, they reduce secretions generally, and there can also be surgery, resection. We go to the tail of the pancreas, we cut away that part. Then there can be radiotherapy. So that's all you need to, at least basic thing that you need to know about vipoma. The next thing we should talk about is the carcinoid disease. Note that the fundamental problem with carcinoid syndrome or carcinoid disease or carcinoid tumor is excess amount of serotonin production. And serotonin is a bioactive substance resulting in the problems that are associated with carcinoid syndrome. I'll be discussing extensively on this in the part 2 of this video, where I will also be talking about malabsorption syndrome, peptic ulcer disease, acute and chronic pancreatitis, and other related disorders. I'm sure you enjoyed this video. Remember to subscribe and watch out for part 2 of this video. Thank you.